Good morning and welcome. This is Alicia Street, and I am the Director of Education for the Home Care Association of New York State. And I am joined by Rebecca Fuller-Gray, HCA's Executive Vice President for Clinical and Program Affairs, who will be moderating our Q&A later in the program. We will be updating the handout slides based on any conversation and discussion during today's presentation, and I will be forwarding that later on after the program. You will find that there is a questions tab. If you have any questions during the program, please feel free to submit your questions using the chat window. I'd like to take a moment to thank the Audacia Foundation, WIO, and Coreactics Healthcare Consulting for their partnership in bringing you what we hope will be a good refresher on infection control fundamentals and tips for keeping your clients and staff safe and healthy during these unprecedented conditions. With us today is Kimberly Nelson. She is a regional nurse consultant for Coreactics, whose years of experience in nurse administration, staff development, program development, quality assurance and performance improvement, utilization management, and information prevention brings an intimate perspective to her unwavering focus on improving quality of care. And Kim, thank you for being with us, and I will turn things over to you.
Alicia, thank you so much. And good morning, everybody. I truly appreciate and thank you for being here and taking your time out of your day today. I know your schedules are extremely busy. So again, thank you. And thank you for all you do. I certainly understand home health environment right now does not look or function today as it did, well, probably even a month ago. And certainly can appreciate the challenges of the healthcare workers and the overwhelming amount of information, excuse me, which is inundating your agencies. It's just nonstop. So in this hour, we're going to take a look and really get back to basics. When we're looking at infection control and infection prevention, we're going to look at focusing on those tools that we all possess, that we have in our toolbox, that we can utilize during those client or those patient encounters, such as your effective hand washing and your hand hygiene techniques. We're going to look at proper donning and doffing of your personal protective equipment or your PPE. And again, you're saying PPE, what PPE? Well, we're going to look at management of PPE conservation, some techniques and some strategies that we can utilize, to really manage the PPE that we do currently have in our possession. And again, it really goes to how we're going to support our staff as we continue and we work through this current COVID-19 pandemic. So again, I truly appreciate being here today. Let's start with some strategies. How are we going to manage those challenges that are related to COVID-19? We can look at pre-admission. Now, when we're looking at pre-admission, we have different settings. We have those residents or those patients, that are coming from alternate care settings or from hospitals, or we have, admissions that we're taking from within the home. Really taking a look at that intake and that screening process, So we're looking at what do we have? Do we have suspected a COVID or confirmed COVID-19? Can we negotiate any PPE? And I know that sounds kind of strange, but when we're looking at particularly that hospital setting, so you have patients that might be coming in, hospitals looking to send them home, but PPE is a challenge. Some hospitals, and again, I understand we're looking at multitude of different counties and regions. Some counties and regions, though, the hospitals do have a lower census. So maybe meeting with those hospitals and saying, yeah, absolutely, we can manage that patient in the home, but can you send us a supply of PPE to get us started until we can get some more? So negotiating that supply. Some hospitals have furloughed their staff. They do have open beds. So that is a bit of a tactic that we can look at. Consistent staffing. and making sure that we have consistent staff going into the home on a daily basis. It really does help not only with the conservation of that PPE, but establishing relationships. When you're in the home and you're working with a patient, if you are that same home health aide or that same nurse that's going in every day, you certainly get a better idea of the needs and maybe the quirks of that patient and how we can maneuver them, as opposed to sending in a new healthcare worker on each visit. Limiting the amount of time the healthcare workers are spending in the home. Certainly taking some consideration into what are those necessary, and I highlight necessary services. Are there services that could be performed in another capacity? Limit the amount, as I said, in the home. Exclude those employees who are high risk for severe illness from coming in contact with known or suspected COVID-19 residents or patients. I'm sorry. So really taking a look at how are we staffing? Are we staffing as effectively as we can? This is a tricky one because it's not confirmed, but according to CDC, individuals who have recovered from COVID-19 infection may have developed some protective immunity. So with that said, is it an option to designate employees who have recovered from COVID-19 to care for those patients who are currently active with COVID-19? Certainly a consideration. So where does it all begin? Transmission-based precautions and those considerations associated. Management of infection and transmission-based precautions is not new to healthcare. It's not new to home care. What is new to the home care and healthcare is certainly the challenge, the sheer numbers and the lack of available PPE that is associated with this COVID-19 pandemic. So really looking at what are some ways that we can be creative and ingenious to those items that are more important, those high need items. So looking at those standard precautions, and again, we're going to do some back to basics kinds of things here. We want to assume that every person is potentially affected with the pathogen, such as COVID-19, which can be transmitted. Hand hygiene, you're going to hear hand hygiene multiple times throughout this. Hand hygiene should be performed before putting on any PPE. Hand washing for 20 seconds with soap and water, or using an alcohol-based hand sanitizer with at least 60% of alcohol. PPE should ideally be put on outside of the home prior to entry. Now, I understand that in every situation, this is not going to happen. So, you know, outside of the home may not be an option. But looking at that entry doorway, you know, prior to or as you're entering the home would be ideal. If you are unable to put it on outside the home, it is important that if you are dealing with a person with COVID or suspected COVID, that you at least have your face protection on, such as your respirator or your face mask and your eye protection prior to going further into the home. Remember here too that the person we're protecting is you. We want to make sure that you are maintained in as safe and healthy of an environment as absolutely possible. So looking at the use of gowns. Gowns are not essential in every scenario. Gowns should be included when we're looking at that standard PPE in situations where you're going to be completing those high contact activities. You know, if you're going to be bathing or dressing, transferring, providing hygiene, linens, you're in close contact with that patient. If you're a nurse and you're providing wound care, you have tube feedings, device care, whatever the case may be, and you're getting close and you're getting close contact, high contact, that's when you want to make sure that you have a gown. Looking at those patients with suspected or COVID confirmed 19, that respirator or N95, I certainly can appreciate again that they are not in great supply. So the alternative to that N95 would be a face mask. if the respirator, is unavailable. We would definitely want to make sure that we're donning eye protection or a face shield, a gown, and gloves. And again, looking at where we're going to start putting that PPE on is going to be at the entry point to that home or in that doorway. So that's very important. Now, I know it's not ideal that if you're taking care of a resident, or I'm sorry, a patient with COVID-19 or suspected COVID-19, that you don't have an N95 respirator. But it is unfortunately the reality right now. These are unprecedented times, and that N95 is in high demand. If you can obtain it, fantastic. But based on the CDC recommendations, currently a face mask would be the next best thing to actually having an N95, so very important. Getting back to basics again, what are those things that, we all know as healthcare workers, we know these points that are very important in our everyday healthcare, and particularly now when we're looking at, high infection. What are the things that not only that we want to ensure that our staff are aware of, and those tidbits to help keep them safe and healthy, but what kinds of things can we go into the home and communicate and educate our patients on, so that their environment can be as healthy as safe as well, particularly since you're going to be entering those environments. Things that we can look at: keeping hands away from face. A lot of these, I know you've heard them all. You've been on other webinars. All you have to do is watch the news these days. But again, the more we say it, hopefully the more we'll remember it. And again, not just for us, but for our patients within the home. Limiting those touch surfaces. Changing gloves if they are torn or heavily contaminated, especially when we start looking at conservation of PPE. You definitely want to make sure that you are inspecting your PPE. So when it does become worn or it does become unusable anymore, that you do take that opportunity to remove it, wash your hands, and start fresh. Hand hygiene, can't say it enough. Respiratory and cough etiquette. Another great thing to teach your patients. Avoid touching your hair. Social distancing, as if you haven't heard that 1,000 times, that's 6 foot of social distancing if it is allowable and permissible. Bringing items into the home, and I know that in a lot of circumstances items aren't being brought into the home, but if you are in a region or a county where you do bring things into the home, maybe you have a bag, maybe you bring a laptop or a cell phone. I just want to make it a practice that when you bring those items, if you bring those items into the home, that we don't just set them down, that we actually put them on what we would consider a clean surface, whether that be a clean towel, whether that be a clean paper towel, not setting those items onto just the original surface. And in turn, prior to leaving the home, making sure we're cleaning those objects. And if they're not leaving the home, we still want to make sure that they're cleaned prior to use. Looking at if you have the laptop, a cell phone, again, if we are talking about blood pressure cuffs, stethoscopes, any of that equipment that you may use while you were in the home. And again, minimizing that time that we're spending. Again, we talk with emphasis on respiratory hygiene and cough etiquette, and it is extremely important, particularly in today's day and age. As of tonight, I'm sure you all have heard tonight, we as New Yorkers are going to have to wear masks in an environment where social distancing or 6 feet is not maintainable or attainable. Certainly a consideration. When we're looking at cough etiquette, we want to make sure we're covering our nose and mouth with at least a tissue if we are coughing or sneezing. Cough or sneeze into your elbow if you don't have. And again, great things to teach your patients. Using a mask, using disposable tissues and discarding after use. Taking consideration to if you have patients that can't get to a trash receptacle, put the trash receptacle near them if they are utilizing tissues and such, so that there is some health and safety hygiene taking place as well. And again, practice hand hygiene. I think the one thing that we may see, and I certainly am very aware of the fact that there's a high level of anxiety these days, and rightfully so. And I feel that with this new information coming down, particularly with wearing masks, you may find that you have patients that want to wear a mask, but we don't have a lot of masks available. We're looking at conservation for the healthcare workers. So how do we provide these masks to really help to ease the anxiety of our patients? I would encourage you to help them make one, if at all possible. Do they have the resources in their home? A bandana, a piece of, a good piece of cloth, and 2 hair ties. If you haven't seen the YouTube videos out there, there is some great resources. And I only say that because I'm not asking you to go out and make all your patients face masks, but if it would help to ease that anxiety and discomfort around this, then certainly there are some methods available to help out. Now, again, we talk, what is our very best defense against infection? Hand hygiene. You're probably thinking, well, I've been doing hand hygiene forever. I'm a healthcare worker. Of course, I know how to wash my hands, and I'm not certainly trying to insinuate that you don't. But I will tell you, statistically, 40% of healthcare workers do not perform hand hygiene the way it should be performed. So it's, again, back to basics. How do we, if we know how to wash our hands appropriately, and how and when to use the hand sanitizers, do all of our staff have the answer? Do they all know how to do that? And later in this discussion, we'll talk about competency, because I think when people feel confident about what they're doing and that they're doing it right, it will and hopefully will help to alleviate some of that anxiety. So I do have a very short video here that I'm going to put on for you related to hand hygiene. So bear with me. It's a silent, but it's got great information. Soap and water. What do I use and when? Hot or cold? Either is fine as long as it's clean. Bar soap or liquid? Either. Does it have to be antibacterial? No, it does not. Plain soap and water is fine. What if I don't have soap but access to water? Well, it's not ideal, but if it's all you have, rub your hands together, wipe it off, and clean with a towel or air dry. When hands are not visibly dirty, you certainly can use that alcohol-based sanitizer with at least 60% alcohol. We should all know this by now. 2 happy birthdays, right? How long do I scrub? 20 seconds. Do I clean under my fingernails? Absolutely. Germs love those fingernails and hiding underneath. Towel or air dry? Either. But if you're going to use a towel, be sure it's a clean towel. Do I need to use a towel to turn off the faucet? I'll tell you personally, I do. There's not a lot of scientific evidence. If you don't have soap or water to wash your hands, alcohol-based hand sanitizer, 60%, at least 60% alcohol. Kills most types of germs on the hands. And definitely want to make sure you wash your hands before eating or after using the bathroom. Protect yourself and others. Wash those hands with soap and water. You look at those hands and you think of all the areas that those hands would touch. I really like to think that when we're looking at hand washing and we're looking at bacteria, envision like looking at those hands, the dirt, picture some kind of a goo almost on your hands, and then everywhere you touch, if you're not washing those hands, you now have put that dirt or goo onto. And it's amazing where you'll find that travel in a very short amount of time. So now we're looking at PPE. We know how to wash our hands. We've got that under control. Donning and doffing. Those are two things, again, that you have control over. And how well are you doing those practices? So it's very important. Yes, you can have all the PPE if you had all the PPE in the world. If you're not donning and doffing correctly, it's kind of a moot point. So again, we do want to make sure that those practices are in place and they're solid. So we're going to walk through the process of donning and doffing. Hand hygiene. It all starts with hand hygiene. Putting on the gown. You're going to don the gown by inserting your arms into the sleeves with the opening in the back. You want to wrap it around the back and fasten at the neck and the waist. Be careful that when you are doing your ties, do a bow, and particularly because we don't want to have you set knots, which is going to make it very difficult when it comes to doffing that material. Your goggles or your face shield. You're going to don that face shield or goggles so that you have that piece that rests on your forehead. If it's a face shield, if it's goggles, it's going to be the eye portion, and it's going to go around the head and fit securely. I do want to mention that eyeglasses are not a substitute for eye protection. If you are wearing glasses for vision, you want to make sure they also are secure and comfortable, but that you have eye protection on top of that. Again, infection control, making sure that when you are wearing those goggles or that eye protection or that face shield, that we're not touching and adjusting during patient care. So making sure you have a good, secure, and comfortable fit prior to providing care is very important. Your mask. You want to secure the ties or the elastic band, depending on what you're using, at the middle of the head and the neck. Again, we want it to be secure and we want it to be comfortable, because the last thing we want to do is go picking and poking at it and readjusting it once it's in place and we are in the work setting. We want to have it be that flexible band is going to fit over the bridge of the nose. We want it to fit snug to the face and below the chin. A lot of times, I know I've seen so many healthcare workers do it where they go and they pinch the top of the nose. Well, essentially what have you done at that point is you've tented your face mask. So you really want to make sure that we don't create that tent. So you're going to take your two fingers and you're going to flatten it out across the bridge of the nose so that it fits snugly and it's in place, and prevents any, bacteria from getting inside. When we're looking at those gloves, it's important that when you wear that gown, that the gown is brought down so that the cuff is towards the knuckles, because we want to prevent that gown sleeve from going up and having any exposed skin. So you want to pull that gown cuff down, ensure there's no skin exposed between the glove and the gown, and make sure it's completely covered. So now we've got all gowned up. We're going in, we're going to provide our patient care, we're going to do our duties for the day, managing and maintaining some good infection control practices. Our shift is getting done. We're ready to go home. We need to doff our PPE or take off our PPE. And I think this is where a lot of questions come in, and this is what probably causes the greater amount, aside from shortages, the greatest amount of question is, how do we take that PPE off? How do we take it off correctly? What do we do with it once it's off? And where do we take it off? One of the things I did find, which I found was very interesting when I was doing some up-to-date research on just donning and doffing. And, I read it at first and it didn't really make sense to me when I thought, wow, this is a new process. But with the COVID-19, it has been added, not through CDC, and I'll be honest, it's guidance as of 4/10/20 through the University of Nebraska Medical Center is where I found it. But as I said, it makes fantastic sense. Prior to doffing any of your PPE, perform hand hygiene. Again, as we would any other time, over the gloves, minimum of 20 seconds or until the hand sanitizer is dry. Well, why? It makes great, as I said, makes great sense. You're going to touch your PPE. Now, when we're talking about PPE conservation, we're looking at trying to manage that PPE for, in some cases, as long as we possibly can, you know, with extended use or with reuse. So the best thing that we can do is clean our hands before we start touching that PPE, before we take anything off. And again, this is an addition to the PPE practices for doffing out by the CDC. Doffing the gown. Carefully untie the gown at the waist and the neck. So now we're kind of going backwards. Doffing the gown, folding the inside of the gown tightly inward into a ball to contain. You want to make sure that all of that, what we would consider contaminated or dirty side, which is the outside of your gown, is now folded in to contain. Once the gown is contained, you're going to separate the gown from the gloves and gently place them into the waste container. Next, we have your gloves. Excuse me. Removing the gloves, we're going to use that glove-in-glove technique. That technique consists of taking your dominant hand and pinching the palm of the non-dominant hand to remove the glove. Then you're going to ball the removed glove into the hand of the remaining glove and use that pointer finger to slide and underneath and free that hand from the cuff of the remaining glove and then remove it. Again, trying to contain any bacteria, virus, anything that would be considered contaminated. Again, we're going to gently place that into the waste receptacle and perform hand hygiene, minimum of 20 seconds with soap and water or until the hand sanitizer is dry. Bacteria like wet, just so you know. Bacteria like to stick to wet surfaces, so we want to make sure that we are at a state of dryness. Doffing of the face shield. The last item of PPE to come off in a patient care area is that face shield. You're going to bend slightly forward, grasp the elastic headband on both sides of your head and pull it away from your face. The face shield, place the face shield gently into the wastebasket, face down. Excuse me. Perform hand hygiene. Again, minimum of 20 seconds or until the hand sanitizer is dry. I'm going to apologize in advance. The only exiting patient care area I could find for a picture, and I apologize, is coming out of a hospital room. I am aware that you are not in a hospital setting. But really, when we're looking at that patient care area, it has got to be individualized based on the physical layout of the home. What does that mean to that particular home? So particularly, we want to get out of that patient care area. I'm not talking about outside of the home, just outside of the patient care area. The only thing you should have on at that point is either your N95 respirator or your mask. You're going to enter that patient care area. You're going to go through the door, step out, ensure that the door is closed behind you. Now, mind you, I do understand in the settings in which you're in, and each one is unique, that may be right at the doorway that you're going to don, or you're going to doff, I'm sorry. When we're looking at, so now what do I do with this PPE? Okay, I've got it all off. You're telling me to put it in a basket, but the basket's in the other room. How should I manage that? Well, let me just start by saying linen and waste do not require any special handling for COVID-19. PPE goes right into the household waste. So in looking at that, it would behoove us to take that waste basket or a waste basket and put it by the doorway where our PPE is being discarded. If we're throwing away that PPE, we want to have that waste basket, excuse me, right near where we are doffing our PPE prior to leaving the home. So we've talked about, this hand hygiene, and then we've talked about doffing and donning of, my screen is frozen, donning and doffing of PPE. But then again, we're asking ourselves, But what happens if we don't have the PPE or we are limited on our supply of PPE? Now what? Well, we're going to look at the conservation. My screen is frozen. And I'm not sure why. But I'm going to keep going. So we're looking at conservation, the key to PPE management. Guys, a lot of this comes down to using really good judgment. Given the lack or the shortage of PPE supplies, in some areas worse than others, I certainly can respect that as well. It's more important than ever that we figure out how can we utilize this PPE to work best for us, to meet the needs of our healthcare workers. We're looking at extended use of face masks. We are looking at reuse of face masks. And I truly apologize, guys. I'm not sure why this screen is frozen. Hopefully we can get it back. So when we're looking at the extended use of face masks, we're looking at wearing the same face mask for repeated close contact with several residents without removing the face mask in between. So we're going from patient to patient. This is where we can use that extended use of face mask. You know, you put it on in the morning. If you are careful, you can take it and use it throughout those residents throughout the day. You're going to remove and discard the face mask if it becomes soiled, damaged, or difficult to breathe through. Excuse me. Be very careful not to touch the face mask. If the face mask is touched or adjusted, we want to immediately perform hand hygiene. And I'll talk about this a little bit further. I think a few of the things that I see very frequently when I'm working with healthcare workers, particularly when we're looking at face masks, is that they turn them into a headband or they turn them into a chin strap, which is certainly not recommended or best practice. We do not want to have that face mask underneath our chin when we're not using it or up, you know, in our hair. It needs to be securely on the face. We're not going to go adjusting the front of that mask. Again, if we need to, then we would need to perform hand hygiene again. When you leave the patient care area, if the face mask needs to be removed, face masks are going to be reserved for use by employees rather than patients. You want to make sure you're keeping yourself safe. And again, I talked earlier, you may have those particular patients who said, I just really, really want to wear a mask. Well, then let's see what we can do to help them out. There may be some things in the home that we can use to help them feel a little bit less anxious and more secure. Instruct symptomatic residents to use a tissue or other barriers to cover their mouth or nose. And again, if we're going to do that, make sure there's a receptacle nearby. Use of the face mask beyond manufacturer's designated expiration date. You know, unfortunately, we are in some unprecedented times, as we say, but an expired face mask is better than no face mask. And inspect your product for integrity prior to use. If there's evidence of degraded material or visible tears, you know, discard it. Make sure it gets put into the waste. If we're going to reuse face masks N95, using the same face mask by one employee for multiple encounters with different patients, but removing it after each encounter. We want to make sure the employee does not touch the outer surface of the mask during care, as we said with the face mask previously. Remove and discard if it is soiled, damaged, or hard to breathe through. Face masks with those elastic ear hooks may be acceptable for reuse. Employees should leave the resident care or the patient care area when the face mask needs to be removed. We definitely don't want to do that in that patient care area. The guidance here is if you're going to take it out and you need to set it down for some reason, put it on a tissue or a paper towel. You want to make sure that there's a protective barrier And when you set that mask down, you want to ensure that the clean side of the mask is the clean side, which would be your towel. So contaminated side up. So when you come back, you're going to pick up those, from the sides, and you're going to put it on so that the clean part that is up against your mouth has not been exposed. Again, we say, residents should leave with the mask removed. But if we're going to reuse it for multiple people, but we're not going to have it, in or on when we go from patient care area to patient care area, the other recommendation is that you would take that face mask and fold it inward against itself so that you're reducing any contact with the outer surface during storage. Storage between uses should be in a clean, sealable paper bag or a breathable container. I certainly have heard or been asked about putting masks when they're not being used into, a plastic Ziploc bag. That would not be an advisable recommendation because that sealable Ziploc bag does not breathe. So basically what you've done now is that you put this contaminated mask into a bag where it's basically kind of going to turn into a petri dish of sorts. Whereas if you take that mask and you set it down on the inside of your brown paper bag, you folded it inward, you put it in the bottom of your paper bag can breathe, and it can be managed that way, and then you can carry it if need be. If the mask is removed during a break or at the end of the day or at the end of the shift, again, you can set it on a paper towel. You can set it on a clean towel surface. You want to make sure that you are performing hand hygiene, because I often hear, well, I'm wearing the mask all day long. Well, what happens if I want to take a break, or what happens if I want to eat or drink something? Obviously, that's not an easy task to do with a mask, but you do want to make sure that you are not in a patient care area where a mask would be required, and that you take it off in a way that, again, you're maintaining the cleanliness as much as possible. And I'm going to re-emphasize again, making sure that we don't turn those face masks into headbands or chin straps, because that's when I quite often will find that staff is out on break and they've put it down underneath their chin. Well, if you think about it from an infection control standpoint, once you put it underneath the chin, which is considered a contaminated area, now you have taken the only clean part of your mask and exposed it to a compromised area. Then you're going to pick that back up and put it over your mouth. So that would not be the recommendation for that. Take it off, set it clean side down onto a tissue or a paper towel if need be. Again, thinking about that bacteria in that sticky goo or those really dirty hand ways. You're in and you're providing patient care, and your hands are now dirty. You have gloves on, but your hands are, they're dirty. They're contaminated. And then you're going to go and you're going to touch your mask, and you're going to, touch your hair and touch all these things. I just really want to caution that would not be recommended. And again, hand hygiene after touching the face mask. Using a cloth or a homemade mask has come up again. Recommendation is that it is not recommended. Though if you were to use it, you should use it with a face shield. Again, we're looking at unprecedented times where that may be the only option you have. It is not best practice, but using a bandana or a scarf would not be considered, again, best practice and not recommended. But if you have a homemade or a cloth mask and you do have access to a face shield, then that would work. That would be appropriate. Face masks should remain in one place on the face for the entire shift and only again be removed if necessary, such as eating or if you really need to take it off to have a conversation with somebody who's not nearby or in an appropriate area. That's the other time that I find that staff will grab a hold of the front of that mask and either pull it out or pull it down when they're trying to have a conversation with someone. And again, that would not be advisable since the outside of that PPE is considered contaminated. So now let's take a look at gowns, another, one of those PPE that I think becomes an issue when it comes to supply. When we're looking at those gowns, extended use. Use gowns that are expired beyond the manufacturer designated shelf life would be the first thing we would do. Making sure that you're inspecting gowns for integrity. Again, is you want to make sure that you don't have rips and tears and open modes of transmission with those gowns. Gowns and coveralls that conform to international standards can be considered. Well, not all of us have access to that, but it is an option. Extended use of isolation gowns. The same gown is worn by the same employee when caring for more than one resident known to be infected with the same infection in the same location. I know that's a lot. If you have, just as an example, say you have a husband and a wife who are both on your caseload, they are patients within the home, and so they're in that same patient care area. Clearly, you do not have to change gown and gloves in between. So you could use and have that extended use because they're in the same area. Again, if the gown is visibly soiled, we want to remove it and discard it. Looking at the reuse of isolation gowns, I will tell you disposable gowns are not recommended for reuse, and that all options need to be explored prior to the reuse of a disposable gown. But again, that's something that you may want to talk to your supervisors about or your agency about, because use your best judgment. We're going again into times where that may be your only option. It is not a recommended a CDC or a New York State Department of Health guidance that we would reuse disposable gowns. Gowns should be prioritized. Using gowns for care activities in where there's going to be splashes and sprays, or there's aerosol generating procedures, those would be prioritized. And there's also the additional option of having a disposable apron. And you can use the disposable apron in combination with sleeve covers, which would actually provide you with that same coverage, that same area coverage, and help to keep you clean. I want to mention there is another Department of Health guidance that came out 3/21/20. I don't really want to use the word guidance, but another consideration that's being looked at when we're looking at reuse of PPE and PPE conservation, and that after, depending on the surface of the or the material that we're looking at, 72 hours, we're looking at a natural death of the virus. So, do we need to look at maybe reutilizing, if it really came to that, reutilizing PPE after 4 days? If it's been in a breathable paper bag and it's been not used for 4 days and not in contact, is that something we need to look at? Talk with your agency, depending on, again, what your supply and demand issues are. It's another conservation method that can be considered. Depending on, again, your location, your region, have we reached out to any of those additional supply services or vendors? Have we been in contact with hospitals or nursing homes? Some areas, again, I certainly am very aware that not every area is running the same, but are there resources out there that we can tap into where maybe there's some open beds and they'd be able to provide us some PPE, at least to help for a little while. Then looking at the extended use of eye protection. Eye protection is going to be removed, cleaned, and disinfected if it is visibly soiled or if we're unable to see through it. Wearing goggles. Carefully, we want to make sure to wipe the inside, followed by the outside of the face shield or goggles using a clean cloth saturated with a natural detergent solution or a cleaner wipe. Carefully wipe the outside of the face shield or goggles using a wipe or clean cloth saturated with this EPA registered hospital disinfectant, Wipe the outside of the face shield or goggles with clean water or alcohol to remove any residue and fully dry. You can air dry or use clean absorbent towels. You want to remove gloves, and perform hand hygiene and discard any eye protection that may have become damaged. Make every attempt to avoid touching eye protection, or if it is touched or adjusted, perform that hand hygiene immediately. And again, when you are leaving that patient care area, remove that eye protection. There is also the use of eye protection devices that we're utilizing beyond the manufacturer designated shelf life. Again, you want to make sure you inspect that eye protection prior to use and discard if it's damaged or degraded in any way. Prioritizing your eye protection for resident care activities. Again, as we said previously, splashes and sprays, if you're doing aerosol generating procedures, prolonged contact, if you're going to be face to face for an extended amount of time with a potentially infected patient and it's unavoidable. And the other last thing is if eye protection is not available, I did mention that, your glasses and such do not count, but you can consider using safety glasses with side extensions. That is an available option. Now, as I said earlier, I understand that not everybody brings a lot of equipment into the home, but if we did, we want to minimize the equipment being brought into the home, certainly as appropriate. When the equipment is essential, we want to assure that these items are placed on a clean surface with a protective barrier. First and most recommended would be a moisture protection barrier. Otherwise, again, we can use paper towel. If it's small enough, you can use a tissue. Taking into consideration as well, though, that not all clients or not all patients may have these items available. So in some cases, you may want to carry that with you if at all possible. Clean and disinfect any of that non-critical equipment, as we said earlier, those blood pressure cuffs, glucometers, thermometers, etc. Clean surfaces and objects that are touched frequently and in close proximity to the patient. We're looking at tables, chairs, handles. If they're using cell phones, if they're using computers, wiping those down for them to really look at that infection prevention. If you do have a car and you take any of these items with you, ideally keep those items or supplies in the trunk, not in the cab of the vehicle. If you're taking transportation, keep those supplies with you, on you. You don't want to be setting them down anywhere or putting them on other surfaces if at all possible. Then I really want to talk, support your team. As we know, and I'm not telling you anything you don't know, now is a time of high anxiety and the unknown and this ever changing, every day we're getting more information. It's important to refer to your specific organization policies and procedures related to infection control and use of PPE. If you don't know, go to your agency and that information would be available. Now's the time to monitor staff to ensure they're aware of and following the appropriate guidance based on your policies and procedures and some of this guidance that's coming down as we move along. Communicate changes to your staff as they occur, specifically during this evolving healthcare crisis. The worst is when you don't know. If all you're basing your information on is what you're seeing on TV and on the news, I agree, it can be extremely scary. But there are some processes out there that we can put into place to really try to mitigate some of the issues we're running into. Provide reassurance, support, and mentorship. Provide education and verify competency related to infection control practices. I think that's extremely important. We may think that our staff knows exactly how to do hand washing or to don and doff PPE, but now's the time to find out, because we want to make sure that our staff is as absolutely protected as possible. And reassure the staff that they're not alone. If you have not had immunizations, one of the things that is out there is if you're getting COVID-19, it's a lot of the issues that are coming from that are related to the pneumonia. Have you had the pneumovac? There's some shared clinical decision making that has happened, but contact your doctors if you haven't had it and you feel you need it. Maybe it's your patients that you feel. But communication is really, really very key in this time and day and age. Have your staff been trained on if they are in the home and they're providing that patient care and they notice a change? And again, this goes back to that consistent staffing again, but they notice a change with the patient. They seem to be becoming symptomatic. I'm doing the bath today and they feel a little bit feverish. I've noticed a cough and some runny nose and sneezing that I hadn't necessarily known or noticed before. Are there new worsening symptoms? Do our staff know when, who, and at what point and how to communicate that so that we are as a healthcare team on top of that? Do our staff know the specific agency policies related to sick leave? Healthcare providers should be regularly monitoring themselves for fever and symptoms. Staff should be reminded to stay home and notify their agency if they are ill or exhibiting any of the following. Develop a fever equal to or over 100 degrees Fahrenheit or symptoms consistent with COVID-19 while at work. If you are at work and you start developing these symptoms, keep on your face shield covering or your face mask and inform your supervisor. Respiratory symptoms consistent with COVID-19, cough, shortness of breath, sore throat. There may be a medical evaluation that's warranted for lower temperatures or for additional symptoms that might be noted, such as muscle aches, nausea, vomiting, diarrhea, abdominal pain, headaches, runny nose, or fatigue. But again, this is where that communication comes in, and it might be based on an assessment by occupational health. Really knowing who am I going to and when. Again, focusing our efforts. I can't say it again, and I truly apologize for sounding quite so redundant, but the two things that we can control right now is not maybe what we have in our arsenal for supplies, but certainly we know what to do with the supplies that we have. Hand hygiene, not only for our staff and for ourselves, but our patients. Do our patients know how to effectively complete hand hygiene? Observing our staff, making sure that they are comfortable with what they're doing and that we are comfortable with what they're doing, donning and doffing of PPE. Again, do our staff actually understand it? Do they get it? Are there questions related to, when, where, how do we take it off? When we take it off, what do we do? Really having those open communication and conversations with our staff, because now is the time to educate and validate that competency, which is not easy because we are not in the homes at the same time. I'm talking about reducing staff in the home, and then I'm saying go ahead and do competency. Utilize videos, emails, phones, set up video chats and Zoom sessions, FaceTime, routine communication. Answer those questions and provide that support, because I honestly think that's what's going to keep our staff feeling, less anxiety at this time. Also, do your staff know your agency specific levels of risk related to COVID-19 and PPE requirements? If your agency has them, are we educating our staff so that they're fully aware of what those expectations are? So that we can best, again, support them. I know that I am coming to the end and I don't have a whole lot of time left, and I want to be able to take a few questions. So I will finish up. And again, I truly want to apologize. I don't know how this PowerPoint froze, but you are all going to get it. But I want to say thank you. Thank you for having me today. Thank you for letting me talk to you about infection control and prevention. And hopefully you got some takeaways that will maybe make you feel a little bit better, or hopefully answered some questions you may have had. But I want to say, hang in there. It's temporary. This will get better. Be proud of what you do every day, because, if you haven't heard it yet, you are essential, and you are truly heroes in your own right. And again, I am honored to have been here today to talk to you, and I thank you all so much for everything that you do. And if you have questions after this that don't get answered, please don't hesitate to reach out to my email. So thank you again.
Thank you, Kimberly. It was an excellent presentation. I have one question that's come to us, and it is regarding sanitizing your gloves prior to doffing. The question is, wouldn't you be contaminating your the container, since most homes don't have hand sanitizer wall mounts on them? Could you provide some clarification to that?
Absolutely. You know, one way that I would recommend doing that, if you're using, you know, you could do it in the sink and grab a paper towel and use that to maneuver your handles. Or you could actually do the same thing with the hand sanitizer. You know, you could take the hand sanitizer bottle, if you have it, grab a clean surface, a tissue or a paper towel, and use that. That's an absolutely great question. So not using your direct contaminated hand, I agree, on that container or on that faucet, but to actually utilize a barrier. Absolutely.
Thank you. I don't see any other outstanding questions. So I would like to, again, thank you for this excellent presentation and the time that you spent in preparing, and assure everyone that the presentation will be posted so that they have access to the entire presentation, even after the part where it froze. Thank you again. Felicia?
Becky, there are a couple more questions. The one question was, can you spray the outside of the mask with disinfectant?
That's a good question, and I will be honest, there's not a lot of guidance on that. It's certainly not a best practice recommendation.
Okay.
I don't want to say yes to that, because again, it's not considered best practice. But again, we're also looking at, are you talking about like Lysol?
I assume so, yes.
Then I would probably say no to that.
Another question submitted was, what is the recommendation for PPE use when you have 2 COVID positive patients in the same household? Do you need to change masks, gowns, and gloves between patients?
You do not, and that would fall under extended use, where if you have two individuals in the same home, you do not have to. If they are infected with the same, they're both COVID, you do not have to switch in between.
And I think
that would fall under the extended use of isolation gown.
Okay. One last question is, when can you stop droplet precautions after diagnoses or start of symptoms?
When can you DC precautions?
Yes.
Okay. That's actually a kind of an extended. There's 2 different ways to determine if you can discontinue. One is test-based and one is symptom-based. We like to say 72 hours after symptoms. But again, that's something that I would certainly discuss as a clinical team, because I don't want to give it a blanket, but I can also get you, and we'll include in the PowerPoint the guidance on that for you. But there are 2 ways to clear that. Again, symptom-based and test-based.
Okay.
And I will get you the exact guidance on that.
Okay. I think that was our final question.
Talk about perfect timing.
So thank you, Kim, very much. And
it was my pleasure.
We'll get out the slides later on this afternoon, hopefully. Thank you very much, and have a safe and well weekend.
You as well. Thanks so much, everybody.